You're watching Helping Registrars Build Skills in Advanced Care Planning, produced by GP Supervisors Australia and presented by Dr. Chris Moy and Helena Roddy. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
So thanks to GPSA for having us. It's a pleasure to be here. So really, on the screen, you'll see the formal definition of advanced care planning, which is a process of planning for future health and personal care, where the person's values and preferences are made known so that they can guide decision-making at a time if the person can't make or communicate their decisions. But really, that's the formal definition. And how can we break that down to our registrars? Something simple. How can we get them to engage with their patients and explain what it is? And really, I like to break that definition down into three main questions that people can ask. So registrars can ask their patients that if they weren't able to communicate or make their own decisions, who would they want to speak for them? What would they want them to say? And do they know what they would want them to say? So that really allows registrars to engage with clients and break that down into a more approachable way for patients to understand what advanced care planning is and to think about answering those questions. So that's how I, as a clinician, really simplify that definition. I think if we start asking those questions, we lead into those really nice advanced care planning conversations.
I must say, sometimes I flip it around the other way. And I'm a bit more confronting sometimes, and I put it to patients that there's a very high likelihood one day in their life when they're either dying or something else is happening in life, they're not going to be able to make decisions for themselves. And in that situation, doctors and other people can't read minds. And what we really need is for them to be able to tell us what they want. And that is in one of two ways. That's either to appoint somebody that they trust to be able to make decisions that they would have otherwise made, or to actually give us some idea of what's important to them and about the things they do or do not want done to them. So sometimes turning it around and actually putting in the realms of autonomy, self-determination, because for a lot of people that's really important. And when they understand it from that point of view, when they lose control, they can still have control by talking about it with others and then documenting those discussions. And it can be an incredible, powerful thing, and then switching it around and giving them that power. The other thing is taking the pressure off others having to make decisions, which are often really onerous and incredibly difficult for them, and placing this incredible burden on their family, for example. So that's another way of thinking about what advanced care planning can be. I think in terms of talking to a registrar about what it is, I would say to a registrar and say, look, bottom line is we're all good at giving treatment, but the bottom line is we need to know what patients want. In fact, it's no point actually providing a treatment or providing care that the patient doesn't want. And there will come a time at some stage where they won't be able to tell us. And in that situation, things become extremely difficult because we cannot read minds. And we're actually often doing a disservice if we're providing treatment that they don't want. So when we're faced with this decision, that can lead to a lot of trauma and disharmony within families and a lot of real pressure and a really onerous, guilty decision-making, which can often lead scarring for the future for families because they don't know what to consent to and what not to consent to. So being able to either do one of two things, that is appointing somebody that can make decisions for them, or voicing and explaining to the rest of the family what is important to them and then documenting this, is incredibly powerful and gets to the very heart of what care should be about, what people want, not necessarily what the textbook says and what is by the book.
So, and Chris, why is advanced care planning such an important facet of the GP's role and responsibilities?
Because we're the ones that know the patients first up, and so we'll know their overall perspective, and we'll have a better picture of their whole situation. The other thing is that we will also have a much better picture of them, about them as individuals, and have their trust to be able to open up these discussions. And the other thing is that we'll also have a better idea about their families and be able to invite families into potentially advanced care planning, which is not necessarily just about the interaction between yourself and the individual, although that may be what they want, but it can also be with others. And so we're in a great position to do this and to be the quarterback. Now, I know that sometimes We all think that it should be left to the palliative care specialist or the oncologist or whatever. But to be honest, when you leave it to too many people, it never gets done. And in fact, we are ideally placed to be able to do this because of the combination of knowledge about the patient, knowledge of the family, and trust.
Thank you. So, Helena, clearly it's an incredibly important aspect of quality care, but really what are the benefits of advanced care planning, obviously to the patient and more broadly?
We'll watch a little video that will hopefully highlight the benefits. I guess I just also wanted to touch on the fact around what it is and how you can explain it to registrars by thinking about why people would become engaged in it. And Chris has touched on some of those topics around autonomy and control and burden on families, not wanting to leave those decisions. So I think that's really important in explaining it, is trying to work out why that person might want to engage in it. And when I've had hesitation from patients, I guess mainly, my background being in oncology, people want to fight and they want to concentrate on getting better and fighting. I always try and present it as an insurance policy as well. So you don't purchase car insurance hoping that you're going to have a car accident, just like you don't complete advanced care planning hoping that you're not going to be able to make your own decisions, but you've got it there just in case that situation arises. So I always frame it to people in an insurance policy. You have it there just in case, the best case scenario doesn't happen. Let's do it, and then we can put it in the forefront and you can spend all of your energy on getting better and spending time with your family. So we've got this little video, and hopefully this will highlight some of the benefits of advanced care planning.
My name is Diana, and Roy and I are husband and wife.
My name is Anita, and John is my dad.
My name's John. I'm Quevy's husband.
So Roy gets to go on a trip of a lifetime. Where does he want to go?
I'd say Bora Bora.
Well, I definitely want to go with Bora Bora.
What food could Anita not live without?
Probably curry.
Anything Asian?
He couldn't live without a lot of food.
And what about you? What food could you not live without?
Probably fruit in general.
Probably chocolate.
That's true.
Anita asking me, so what's this about? I said, I don't know.
If you can think about a moment where you pushed through a hard time together, can you describe that?
At school, when she was being bullied, we had to see some counselling.
Just talking me through it and helping me get through it. Kind words and lots of hugs.
For me, it was probably the time when we were first trying to have our first child, I guess. We went through IVF and things like that. Becoming parents is something that we all hoped would come naturally, but it didn't to us initially, and we worked through that together.
Roy's hurt in a car accident. He needs a breathing tube for the rest of his life, and he'll never speak again. Would you consent to this?
Well, yeah, I would, yeah.
No, I wouldn't. Definitely not. I don't think I would want to burden anyone with that. So I'd rather not. Yeah.
Anita had 3 months to live. Treatment would give her an extra 2 months, but she would never see outside of a hospital. Would you consent to treatment?
Yes, this was a difficult one, this one. 2 months, it's just 1 week, 2 months, any time.
Not at all. No.
That's unexpected.
I don't want to be kept in a hospital for forever.
John has had a massive stroke. Does he want a feeding tube to keep him alive, even though he'll never talk again?
No.
No, I don't. It's very important to me to be happy and functional in my life. No, I wouldn't want that to happen.
Roy's in the last stages of terminal cancer and his heart stopped. Does he want CPR?
Probably not. I don't think you would, no, I don't know.
So how do you both feel after answering those questions, and why?
It felt quite confronting in a way. But
You think about it and you talk about it just very lightheartedly, but I don't think anyone really puts a lot of thought and serious thought into it.
No.
Why do you think that some couples don't talk about this?
It's not a pleasant subject. I mean, nobody wants to dwell on the fact that they're going to die one day, and possibly in adverse or difficult circumstances.
So if I was to tell you that advanced care planning is essentially a conversation that helps your loved ones know what medical treatment to choose for you if you had a sudden event, what would you think about it now?
I think it's a great idea.
Yeah, absolutely.
It's important not just for yourself, but more so for your family, I think.
Definitely have to have a bit more of a talk. And it's not just about the two of us. We also have kids and all that kind of stuff, yeah. So there is a bit we need to consider, yeah, 100%.
So I hope that's answered that question of what the benefits are of advanced care planning. And something that always strikes me when I watch that video is the emotion that comes through from the families. Really looking at it, they know that their loved one is next to them, is healthy, is well, but there's still this emotion that comes up. And it just really highlights that intensive care, emergency departments, when you get a phone call from a residential aged care facility, that's not the time to be having these conversations. The time to be having them is when people are well, when our patients are well, when they can tell us what they want. And those benefits really are for the person to have that autonomy over their own decision making, and for the family to reduce that burden, as well as obviously for ourselves as clinicians and for the whole hospital and healthcare sector to really not be giving and wasting treatments when they don't really align with people's preferences. But hopefully that highlights that everybody can benefit from advanced care planning, and really any of us can have a sudden event at any point in time. And as much as we consider these things for our patients, I challenge all of us. How many of us have done our own advanced care directive? How many of us have had conversations with our own families? And how many of us have prompted our registrars and our team to have those conversations as well? So really, if we're encouraging our patients to do it, the first step really is to do that for ourselves as well. And that will give us insight into how challenging it can be to think about these things. But the benefits really are for everyone. And I'm sure, like most people working in an oncology ward for 12, 13 years, I've seen times when this has gone really well. People have made their wishes known and it's very clear. And then we have the times when people haven't, and we've got that conflict with the family, those complex issues that arise, and just not being aware of what the patient would want, and it's too late to find out. So really supporting patients and supporting our registrars to have these conversations and participate in advanced care planning while they are well helps to alleviate this conflict for us, for our patients, and for their families as well.
I was just going to say that I think, in summary, I mean, look, bottom line is that you get patients who are not ready for this, or will claim that, I've had patients being, why would I want to do this? This is like a death form or something like that. But I think you sometimes have to turn it on its head and get people to understand, first up, there will become a time when you're not going to be able to make decisions. We all have different values, as you can even see on that. Even people that love each other have very different values, and doctors often have very different values to their patients, that we can't read minds about treatment, and that the decisions are extremely burdensome and can leave people with guilt for many, after death. And that's the biggest thing. You leave families with a burden. And so this is actually potentially a gift for them by doing this. You're actually giving them a gift. And look, I remember one of my favourite memories of this was an elderly man who was a judge who had severe diabetes, was in a nursing home, and he was a very dignified sort of chap. And then he started developing gangrene in his leg, and we developed an advanced care plan, but we revised it, and we had a family conference and talked about this, what we wanted to do, what were things that mattered to him. And one example we talked about was what happens if you're going to lose your leg. Would you lose your leg or not? If we take your leg off, you might live. And he actually said, with everybody there, he said, and this was such a tough decision, he said, no, I'd rather die. And he was in a nursing home and he was very ill, and we let him die. He was allowed to die. He didn't have treatment for it. He was allowed to die peacefully. We gave him palliative treatment. And then one day the daughter came back to me, in tears, and was in terrible guilt, saying, why, we should have done something. And I was able to take her back to that decision, that meeting that we had. And I told her that was the loving thing. That's what he wanted. And that reassurance that we had gone through that plan and actually gone through what was important to him made such a big difference to her, because she wasn't going to live with this guilt, because she remembered that's exactly what he wanted. And in fact, he'd given her the gift of actually telling her what he wanted.
So in 2019, Advanced Care Planning Australia did a national prevalence study. So we looked at 4,187 Australians. They were aged over 65, so what we'd consider an older cohort, and only 14% had an advanced care directive in their health record. So when we break that down, it was 6% in general practice, 11% in hospitals, and 38% in residential aged care facilities. So in general practice, around that 5 to 6% mark. When we look at it as an overall cohort, it is 14%, but really bumped up by the residential aged care facilities at 38%, which is still not a very high number for residential aged care as well, and very minimal in general practice. But when we look at these, only 20% of Australians aged over 65 with cancer had an advanced care directive in their record, 32% with dementia, and 28% of chronic kidney disease. So quite minimal considering people with chronic health conditions. And if we looked at this on a population level, it would be even lower if we considered those without or were under 65 as well. So overall, the low prevalence really indicates that advanced care planning is not part of routine care, that the organisational systems are not in place to support it, therefore older people, but also for the general population as well. And that's really concerning, given that most older people, older Australians, only 7 to 9% when we surveyed them wanted life-prolonging treatment. A lot of them didn't want life-prolonging treatment, but those wishes aren't made known. So primary care services, GPs, really need to make sure that there's adequate access to palliative care for older populations, but also really making the space for these conversations. So such a small percentage of people over 65 wanted those life-prolonging treatments, but again, only 5% really are documenting them. So how do we know? As Chris has said multiple times tonight, it's really hard to be mind readers and to work out which of those actually want what type of treatment and not. So I think that's really where our role comes in as clinicians, as GPs, that crucial role in making sure we have the conversation and also the documentation to support it, and really helping our patients navigate the system and ensure that once they complete that documentation, that it's uploaded onto electronic medical records and that they share that documentation with everyone involved in their care as well.
And one of the things I really like about these educational events is to think about the ripple effect and empowering to be champions of this, really. And so to go back to your practices and say, this is a real issue. It's such an important area of practice, and yet figures would say that it's infrequently done. How can our practice, not just myself or my registrar, address this, and indeed more broadly? So how, Chris, can a GP supervisor best identify triggers for advanced care planning discussions? Let's think about the general practice context. When should a registrar think this might be an opportunity to put some of this into practice?
These are potentially some of the triggers. There's a tool called the SPICT tool, SPICT, which comes from the United Kingdom, which is a clinical criteria to actually determine if this individual has a reasonably high likelihood of dying in the next 12 months. And so it looks at things like criteria like diagnoses, combination of diagnoses, as well as the actual functional capacity of an individual. So, for example, it might be level 3 for renal failure with inability to mobilise more than across the room. Those sort of things are the sort of criteria which could help you start to decide. Because I think one of the problems is we have so many criteria for everything else, but we don't have criteria to trigger us as to when we might start thinking when this might be useful. So SPIC tool is actually a very useful criteria, which you can just put up in your room and start to think this out. It may be the sort of thing that may be helpful for you. Other things are significant change in health or healthcare needs, and that's pretty obvious. Loss of capacity. The problem with loss of capacity is you want to do this before they lose total decision-making capacity, really, because that's what you want to know what the patient wants to know. The surprise question is, would you be surprised if this person died in the next, say, 6 months, or flip it around? Would you be surprised if this person was alive in the next 12 months? I mean, there's sort of questions to ask yourself. 75-year-old check is a really good time to be thinking about advanced care planning. And of course, the diagnosis of a significant chronic illness, and obviously a major diagnosis such as cancer, for example, they're all really good times to do it. Now, obviously, you have to be sensitive and pick your time. And that sometimes becomes a problem because there's lots of reasons not to do it. And you often put it at the bottom of your list. But understand that, just as we've just indicated before, but so few times that people do this. The problem is for all our wonderful healthcare that we provide, it's absolutely no use if it's not what the patient wants. This is why it's so important to start thinking about how you might incorporate that into your thinking on a regular basis to be able to bring this up as a topic.
To Helena and Chris now, so who can participate in advanced care planning, and basically how's it done?
Anyone can participate in advanced care planning and in those conversations. Really where the nuances start to come in is who can complete an advanced care directive or those legally binding forms. And that is people with capacity can complete those. But that doesn't mean that all of our patients can't participate. Even those who have lost decision-making capacity can still make their values known and their preferences known. They might not be legally binding or able to make those legally binding medical treatment instructions, but they can certainly participate in the process and let us know what quality of life is and what's important to them. So really it is for everyone. Where people don't have capacity, they can fill out an advanced care plan, which is not legally binding, or participate in goals of care and those more informal discussions rather than those legal processes. But Chris, did you want to talk about capacity?
So yeah, look, a lot of people get a bit frazzled about this concept of decision-making capacity. You probably get letters from your lawyer sometimes, does this person have decision-making capacity? And decision-making capacity is not well understood, and people think of it often in terms of they've got dementia, they've lost decision-making capacity, or they're drunk, they've lost decision-making capacity, or they've got intellectual disability. No, in fact, decision-making capacity is actually pretty enshrined in law as this principle, which is it's not a medical diagnosis. So an adult is presumed to have decision capacity unless there's evidence to the contrary. So first up, it's presumed. You start from a presumption that they have decision-making capacity. It's also task-specific in that it's only relevant to a specific decision that's being made. But it has 4 components. So for a person to be able to make a decision, it's very common sense. You have to be able to do 4 things. You have to be able to understand the information you've been given. You have to be able to remember enough of it to keep it in your head long enough to be able to put 2 and 2 together. You have to be able to then reason and weigh up the risks and benefits. And then you have to be able to express the decision in any way. So there are 4 things. So you have to be able to understand it, keep it in your head long enough to make a decision, be able to weigh it pros and cons, and then be able to express that choice in any way. If you can't do one of those, that's actually impaired decision-making capacity. And that's when an advanced care plan or advanced care directive, which has been completed by somebody who had decision-making capacity at the time, comes into effect when they've lost that ability they've got impaired decision-making capacity and they can no longer make decisions. And that's what we're planning for that time where that person can no longer maintain decision to be able to make the decision about, for example, end-of-life decisions because they're unconscious or they're too confused or they're psychotic or any of those things.
So I guess practically, how can the supervisor then educate their registrars on what it actually looks like in practice?
The first step is being aware of it, like a trigger to being ready for it. It's about decision-making capacity. So let's think about it. Okay, I'll take a step back. Our problem is that when we're faced with somebody who has lost decision capacity when they're dying, for example, a doctor is going to be faced with all these thoughts that go through their head. And we'll go through each of these thought bubbles. The first is that there are many of us who believe that life is sacrosanct. That's all that matters. What are the clinical parameters that will tell me that the life is at the end of their life? They'll just be focusing on those sort of things. What is the protocol in this situation? What did the textbook say? What did the consultant do the last time? We do a lot of that. We actually look back at what our mentors did and what the textbook said. My job is only to save lives, isn't it? That's the sort of thing that goes through our heads. What's best for this patient? Now, a lot of us fall into the trap of only thinking about what's best for this patient, which is actually what we believe is best for the patient. But in fact, that's called best interest decision-making capacity, and it isn't always necessarily what the patient wants. What's the legal situation if I don't give treatment? Maybe I'd better keep trying to keep them alive. And I'm afraid we all fall into this trap, unfortunately. His children are saying, well, we should let him go, but his wife is saying that we must keep him alive. What do I do? That's a common dilemma. I don't know how to tell them this bad news. I need to give them hope. Maybe I'll give them one more round of treatment. I think we can all say we've been down that line before. What's this bit of paper, an advanced care directive? What's his plan? Who is this person calling themselves a medical power of attorney? Who do I listen to? And finally, what would this patient have wanted had they been conscious? Now, I've just taken you through all those thoughts about the sort of thoughts, I'm going to tell you now, all of us, particularly earlier on, we get really muddled in our thinking because all those things come to mind and really confuse us about what we should be doing. God knows what families or loved ones of somebody who's dying is going through as well. And they're going through similar thoughts about what we should do. And ultimately what we should be doing is actually doing what the patient would have wanted had they been conscious and able to make the decision, had decision-making capacity. And this gets back to the idea of focusing on what they would want had they been conscious and being able to have this discussion earlier on so that we can actually all agree and everybody's on the same page, and then document it in some way so that we firstly either write down what their wishes are or document it. And also, if it's a legal document, and there are different legal documents in different states, document somebody who will be able to make the decisions for them and be able to stick to this, be able to be brave enough to stick to making decisions based on what they believe the patient would have wanted had they been conscious. And I always get back to this. Whenever I have a family conference, I sit down and I say to everybody, okay, this isn't about us. Okay, this is about this person here. Our job is to actually come together to try and actually understand what your father or your mother, for example, want, and go through this. And then at some stage, get this documented. And so that we're all on the same page, so that another time, another place, if they can't make those decisions, we can all hold together to be able to do what they would have wanted had they been conscious.
Some of the practicalities really is letting registrars know about the terminology. As we've seen lately, the states and territories across Australia don't agree on much, and advanced care planning is no exception to this. So every state and territory across Australia calls the actual document something different. The national term for it is an advanced care directive, but as you can see, there's advanced health directive there for North Queensland, as well as advanced health directive in WA. So there's a whole list there. And the person who's appointed to make decisions, again, can be called a variety of things, but the national terminology is a substitute decision maker. So make sure that your registrars are aware of what the terminology is in your state and territory, just so that everybody's talking the same language, the patient, the family, and all people involved in their care. But really, it's about starting the conversation, so introducing those conversations. And that's really what's so important, is the conversation. Yes, the forms are important and the advanced care directives are there. I've put a few examples of the actual state-based forms. So we've got on the far left WA, in the middle New South Wales, and Victoria on the right. But the conversation and actually initiating those conversations is one of the most important parts. And yes, then we can document them in the advanced care directive forms. But what can actually people do in those forms? Really, every state has their own forms, but they answer those three main questions that I said at the start. So who would you want to speak for you? It allows a person to appoint their substitute decision maker. Who's going to answer those questions if they're not able to? What would you want them to say? So they're able to document their values or preferences. So these aren't legally binding, but what I would often encourage people or our patients to put in there is things that are going to guide their care. So, for example, life would not be worth living for me if I was unable to recognise my family, or I wouldn't want life-prolonging treatment if I was cognitively unaware of what was happening around me. So really those fundamental values that they want decisions to be based on. And then particular medical treatment instructions. So these are the ones that people can consent to, refuse, or withdraw from any particular treatment. An example of this might be, I would not want blood products or transfusion of blood products under any circumstances. So being very clear about what the treatment is and what the circumstances that they would want that to be. And encouraging people to think about those treatments in short term and long term. So if we ask most of our patients who would want to be on long-term ventilation, most of them would probably say no, but would that be acceptable if they were on a ventilator for a short period of time recovering from surgery? So posing both those short and long term and encouraging registrars to think about it in that context as well, so that when we go back to these documents, they actually are quite meaningful. I guess the main thing is as well that our patients don't have to do everything. So just because the form has all of these components, somebody might just want to appoint somebody to speak on their behalf, or just document their values, or just leave instructions. So you don't have to complete the forms from start to finish, and people can really participate in whatever aspect of the process they would like to.
With regards to appointing somebody to make decisions for you, a tip, don't think that it's always the person that loves that person the most. It's got to be a matter of trust and the ability of that individual to be able to make the hard decisions. You can have some family members for which they're totally unsuitable to be a substitution maker. They may love the person, but in fact, they may love the person too much or not have the sort of personality to be able to follow through on the decisions. Then they wouldn't have actually done what the person wanted. They may make decisions for their own needs, not the individual. Now, that's a hard thing to say, but I often say to people, you need to be able to appoint a substitution maker that actually can be able to stand up to make the decision that you want. The other thing is that I think often we focus only on the negatives, like I do not want resuscitation, or I don't want intensive care, or whatever. But values and preferences, which are positive, are actually sometimes just as important. And I'll give you an example. I mean, sometimes just writing things like, my family is really important to me matters, because sometimes, for example, I have given an extra transfusion to somebody to keep them going so that their family member can come and see them again one more time, because their family was important to them. Knowing that a positive thing is actually important is just as important sometimes as just focusing on the negatives. So that's just a tip that I've found over time, because it actually adds a lot more value to the interaction rather than just, I do not want this. And we focus too much on that sometimes.
I've got a great story of actually decision maker. I was working with a young adolescent who had a chronic illness, and he had completed his advanced care directive and had the conversations, and he approached his mum to be his substitute decision maker. And she very wisely said, I'm sorry, but I can't be your decision maker. I'm your mum and I love you, and I'm going to want you here in any form. So, I can't make those decisions and make those calls for you. So he was able to appoint a friend who could do that. So I think that's part of our role, is explaining what that person's going to do and encouraging them to appoint the right person as well.
What are some of the sort of practicalities that GPs and GP registrars need to be aware of regarding advanced care planning? Who can help support registrars as part of the GP team to do that? How to do this really well? So can I ask you to speak to those very practical things around how to do it and to do it really well?
So one thing is that things like the 75-year-old assessments is quite a nice non-emotive arena to bring up the subject. So that's one area, but quite often just to bring it up and actually be able to provide individuals with the forms and some of the information. But I think the GP is then often in a great position to start fleshing that out, about opening this up, having used that as an opening to be able to flesh it out and actually explain some of the things we've talked about for why it's important, that it's about self-determination for the individual. It can be a gift to your family, and that it can make a big difference when you can't make decisions anymore. And then sometimes it's a multi-stage process. You will actually have a talk with the individual first, because you open it up, the idea, but then you remind them the next time then you say, look, let's make an appointment at some stage to actually talk this out. And then you might say at some stage, or if they're ready to bring the family in, they might want to bring the family in. So you can either do it with the individual first and then bring the family in last time. It is sometimes a multi-stage process. It's not necessarily just a one-off thing. Now, I know that sounds hard work, but to be honest, sometimes they're some of the most gratifying times when you have with your patients, because you'll actually really be able to get to know them a lot better and really get to know what they want, but also be able to get to know their family. And it can be extremely rewarding actually bringing the family on board with the care of what their loved one really wants in the future.
Practically, things like billing. We're now working in an era of telehealth, which I know has diminished somewhat, but how do we sort of navigate Medicare in doing this?
Certainly, telehealth is quite a good option because it can potentially, I've done a lot of advanced care planning, sometimes with the individual there and with other people involved getting into it. Unfortunately, obviously, it's going to be stuck primarily within the normal item numbers. There is no specific item number for it per se, which is unfortunate because sometimes it can be quite time consuming. So I think it's a good idea. It's the sort of thing you will need to book longer appointments for in general and plan for them and have enough time. I mean, stick them at the end of the session or end of the day rather than in the middle of a thing where you're rushed, I find, because you never know how long sometimes these are going to take.
You did mention 75-year-old health checks, and I think another opportunity is just general GP management plans where we know patients are chronically unwell and may indeed have terminal illnesses. That may be a trigger to have these conversations. So, Helena, what other practical things can we equip our registrars around doing these things in general practice setting who can help with a good advanced care directive?
It's important to remember that this could be a team thing and it doesn't have to be just the GPs. You might initiate the conversations, but what are the roles of practice nurses, of other allied health in the team to support those conversations? It might be as we do a chronic disease management plan that's a flag, and then that the practice nurse brings up or follows on these conversations with them as well, just to limit the time that you're spending, or you might have some touch points in there, but a lot of these conversations are had with the nurse. But we know that time can be an issue. And so Advanced Care Planning Australia also has a support service. So you might initiate the conversation. You can then refer your clients onto that support service to help them through the forms, the process, and then they come back to you with some completed forms or some prompts about what they want to do and what they want to achieve. And then you're just following up on those rather than helping them work through all of that documentation as well. I think it's also really important to think about storage. What do we do after we complete these? So making sure that they're uploaded to your electronic medical records, but giving the patient copies, telling them to hand it out to their substitute decision maker, their family, leave it with their medication, but really, if they can, uploading to My Health Record as well, or giving the practice permission to do that as well. So communicating with everyone involved. The time that, one of the siblings or children finds out that they're the substitute decision maker is not when these things are enacted, but that they all know early.
Can I ask you both, what are your take-home messages? I'm going to give you 3 each for how supervisors can build capacity in their registrars in this particular aspect of practice.
I think my biggest take-home message is have the conversation. There's never going to be a perfect time to introduce the topic, and there's always going to be other priorities, but have the conversation. And really, from all of the patients, all of the research, patients want us to have these conversations with them, and we might feel a little bit uncomfortable about how we do it or when the timing is, but they want to have these conversations. So open the door. It doesn't have to be a half-hour conversation. Introduce the topic, have a chat about it, and get in there. And also encourage your registrars to really look at where their skills are. We've got lots of resources, but to build skills in particular areas if they don't know about legal aspects, if they're not sure. So encourage them to have a look, and that there's so many supports and resources. They don't have to do it themselves.
So, Chris, what other take-home message would you encourage?
My quick top 3 would be, look, we do so much about learning how to save people's lives and treat them, but Really, advanced care planning is so important because it's not much point if that's not actually what they want. The importance of actually knowing what individuals want is really critical and really do a disservice if we don't help assist patients to be able to express those wants. Try and incorporate it into normal work and start to think about it. Things like the SPICT and all these things are the sort of things that may help you start to move forward with actually making it a bit more rigorous and bringing this up as a topic and not make it the last on the list and putting it at the back. And also a lot of it is there's a set way of doing this, but I don't think there is. There needs to be a lot of flexibility, and part of the art of general practice is that ability to find the right moment and actually be able to then work with patients in a flexible way to be able to do this in a way that suits them and that is most satisfying in terms of the result.
And an interesting question about Aboriginal health services and who is best equipped to initiate conversations, the doctor, an Aboriginal health worker or practitioner. I imagine it's really the person who knows the patient best or about relationships. Do you have a comment to make?
There doesn't have to be one person who initiates the conversations, and I think the more people that raise it, the better. Patients will respond differently to different people and engage differently. So there doesn't have to be one person whose role it is, and there is actually benefit in multiple people and hearing the same question, the same introduction from multiple people. So we don't have to worry about introducing it or leaving it to one person.
The Advanced Care Planning Australia website is a very rich repository of resources, so please have a look. And we would very much like to thank Advanced Care Planning Australia for supporting Helena to come and Chris to join her for what I think's been a fabulous conversation around just making space to have this dialogue with patients and patients' families. Thank you so very much.
Pleasure.
Thanks for having us.
GP Supervisors Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.